So, as he said, I run the pulmonary rehab inpatient and outpatient programs at Tampa General Hospital. Mostly we to support all of the local physicians as well as the lung transplant clinics, so get patients from all over the place. Just a quick run through just pulmonary rehab. Most of y'all know what all it entails, but you know, we do assessments, monitoring our patients while they're exercising. It's exercising, breath retraining, education. One of the big things we do almost every single day is oxygen use and safety. It's amazing that sometimes people just kind of need to be guided how to properly use that oxygen when they're exercising. The goals of pulmonary rehab for pre and post treatment or just living with a lung disease, those goals pretty much are the same. It's there to increase your strength and endurance, help you with symptom management, again, whether you're pre or post, and really to better your quality of life. So, onward. So post-transplant, which is what we're here to talk about today mostly, post-transplant, you can't exercise like you do pre-transplant. Obviously, you're going to be under sternal precautions after you've had a lung transplant surgery. So that means you can't just go lifting weights and doing exercise bands and not paying attention, because you have to protect not only that incision, but you're also needing to protect inside where they attach the lung, the anastomosis sites. So I frequently have patients, their pain is, you know, a 0 to a 1. They feel great, they can breathe, and they're telling me all this stuff. Oh, I helped my wife in the garage move some stuff around yesterday. I'm like, no, you know, they're 6-8 weeks out, but the pain is gone, and it's so easy to forget. Inside is still healing. So we're constantly reminding patients of those sternal precautions. You shouldn't be doing anything without being released from those precautions by your physician. If he wants to release you early, let your physician make that decision. That shouldn't be because you think you feel good, because you're not going to feel any damage inside until it's too late. With post-transplant exercise, early mobilization is key. Our patients at our center, if there's no reason not to, you come out of the OR, you can be extubated within hours if everything is lining up perfectly in textbook, you know, and you're up out of bed in the chair. I mean, they waste no time. And when that happens, here comes pulmonary rehab. We're coming in there, we're either coming with PT and OT and we're going for a walk already. If you're still a little loopy from some meds, that's okay. I'm gonna come at you with those cycles, and probably most of y'all in here know what the ergonomic cycle is. The little cycle we put in front of you and have you get going on it, okay? It's important. It's important for a lot of reasons. We want to start building up that strength right away. We don't want to give you time to sit and decondition because you had a surgery. Once you're, like I said, that'll begin even in the ICU in most cases. Once you come out of the ICU, you're definitely going to be ambulating in the hallways, chest tubes and all, but we're walking. Okay, that's the quickest way to get out the door. Once you get discharged and go home, now you have an order for outpatient pulmonary rehab sent in most of the time, unless you're already super active. So in outpatient pulmonary rehab, it's again gonna much be the same as what you would have done pre-surgery. We don't want you to get any more deconditioned than what the surgery may have gotten you. Not everybody is in and out. Everybody's journey is a little different. You may have been out in 10 days, you may have been in the hospital for 2 months, whatever the case may be. We're gonna meet you where you are in pulmonary rehab, and we're gonna go from there. I've had patients come in and start at the very baseline of what we would start most people, because that's all the strength they have. I have other people that come in and they're right on the treadmill, walking faster than my normal walk. So we're gonna meet you where you are, and then we're gonna advance from there. And all the while, making sure that you haven't forgotten the breathing techniques you were taught. You haven't forgotten how to recognize that overexerted feeling and when to stop and take those breaks. So the low impact aerobic exercises are the biggest part of probably what you're going to do, but we still don't want you to lose a lot of strength. Oh, goodness gracious. Back up. Post-surgery precautions, just in case I didn't mention all of them. They're basically, you're not pushing yourself up to get out of a chair. You can't use your arms and push yourself up. It's all legs. It's all legs getting up. So I don't know how many of y'all are familiar with the sit to stand exercise. That's why we harp on those in pulmonary rehab. Do those sit to stands. Even if you don't know if you're getting transplanted, do them. That way you'll be ready. Dressing and bathing, you're not reaching behind your back with both hands ever to do anything. You're not going to lift your arms up above shoulder height. You're not grabbing things out of the kitchen cabinets. These are things you need that support for. That's what you need your caregivers for, okay? You're not reaching up above your head for anything, and you're keeping any kind of lifting or anything to 5 pounds or less on each hand. Now, that being said, you're going to come into pulmonary rehab post-transplant, and we're going to monitor you. If you don't do pulmonary rehab, this is important that you're doing this on your own if you're doing exercises at home, okay? So always be monitoring yourself. Yeah, you got a new set of lungs, and since you left that hospital, your oxygen saturations haven't dropped below 98%. You're good. They're new lungs, right? So you might tend to think you don't need to monitor as closely, but you do. When you're exercising, just as we do in pulmonary rehab and as we will continue to do, is monitor those oxygen saturations and heart rate while you're exercising. You're looking for any kind of trends, especially post-transplant. Okay, you want to make sure that things are staying steady. Heart rate, oxygen, respiratory rate. In pulmonary rehab, we'll also still do those blood pressures. And we also use what's called an RPD or RPE scale, which are shortness of breath scale and an exertion scale, and I'll show you those in a later slide. So the benefits of jumping right at it are going to be to increase that strength and endurance. It's going to be to help with the flexibility, get some flexibility back. Exercising helps prevent osteoporosis. You probably have already been on all kinds of steroids. You're going to be on steroids post-transplant. So again, in that aspect, exercise is important. It's going to reduce your strength and anxiety. It is a very stressful time. Again, that's why you have those resources and that support team around you. But exercise is a great outlet. Increase your energy levels, maintaining a healthy weight. Go back to those steroids again. Some people struggle a little bit. Some people struggle with not being able to gain enough weight. That's a whole different set of problems. So when you're seeing somebody in pulmonary rehab, we usually have a pretty close relationship. I know we do in our center with the transplant team, and we're on it. We're messaging them when we identify any of these issues. And then just exercise can increase an overall sense of well-being. So when you start to exercise, you're going to start slowly, okay? Like I said, we're not going to come in gangbusters. When I say we're going to come at you with that cycle, we're not going to come in there and ask you to do this for 30 minutes. You know what? I've had patients do 2 or 3 minutes, and they're like, I can't. I'm done. I'm exhausted. That's okay. So this is where we start. And then we just continue, and we monitor each time, and we just add, I don't care if it's 15 or 30 seconds that we add the next day, but we're going to add a little something, and we're going to slowly build you back up. At home, you want to set up a schedule. You want some sort of exercise every day, even if it's just some warm-up and cool-down type things in the very beginning. Don't jump at climbing stairs and things like that. Keep things on level ground, okay? Especially in the beginning. You don't want to risk any falls. Again, after surgery, you got those sternal precautions. Falling could lead to bad things. So keep yourself on some level ground. We use what's called a FIT principle in pulmonary rehab as far as making basically a exercise prescription for our people. And basically what that stands for is frequency, intensity, time, and type. Okay? So the frequency is how often am I going to do this exercise? So you want to start at, if you're coming to outpatient pulmonary rehab, you're going to come 2 to 3 days a week, depending on the program. The goal is 4 to 5 days a week, you should be doing some sort of exercise. So if you've got those 2 or 3 days and you're coming to see us, the other days you want to be doing something small independently on your own, with staying within those precautions. Don't exercise in extreme heat, extreme cold, or humidity. Things that make it very uncomfortable to exercise. I have patients that go to the mall. The mall's open before the stores do, so you don't have a crowd. There's usually places to sit, and it's air conditioned or heated. I forget, some of y'all are from the cold places, so it might be heated. Another thing, I've got patients that go to the super Walmart and they need 1 or 2 things, but they walk every aisle in the store because that's how they get their steps in the AC in Florida. So these things can work. Keep in mind, if you're post-transplant doing these things, mask up. Use your hand sanitizer. You got to be aware that you are compromised as far as your immunity goes. So those scales that I talked about, that falls in the intensity on the FIT plan. So the RPD scale, this is the shortness of breath scale. It's a 0 to 10, and it's okay to be short of breath. People with lung disease tend to, especially once they get a diagnosis, they get short of breath and they stop. They don't know how far they can push themselves. They don't want to end up in the ER. I mean, it's totally understandable. This is a very real fear. So the goal is the green in this slide, that 2 to 4, which is slightly short of breath, moderately short of breath, or somewhat severe. Now, these are very subjective. So these are just kind of ideas of where you should be. If you can carry on a conversation while you're doing an exercise, you're okay, all right? When you start having to break up your words, you're dipping down into those orange and red areas, and you need to back off, take a break. It's time to take a break, okay? The RPE, this is the exertion scale, all right? On the exertion scale, we go 10 to 12. Again, it's the green area, or 11 to 14, it's the green area. So a light exertion all the way to somewhat hard. So in other words, you're thinking about how hard am I working to do this exercise? And you can go back to, can I talk to the person next to me while I'm doing this? If you can't, slow down or stop, catch your breath, all right? The time. So the time is how long am I doing the exercise? In light of what we just talked about on that intensity, if you are able to carry on that conversation and you can exercise, say you're on the recumbent cycle, okay, the stationary bike, and you're able to have a conversation, you feel like you're working out, it's getting a little hard, but you're still in that green range. You can still say a sentence, all right, and you don't have to break up those words. You can keep going. Your oxygen is good, your heart rate is within your target heart rate limit. You can keep going. We watch closely when we're exercising our patients. We check those 2 scales right smack in the middle, or anytime we look at the patient and they look like they're really struggling, but they're trying to push themselves. We'll go over and say, on this scale, where are you at right now? So to kind of teach you where to keep yourself. So you can do the very same thing at home. Balancing activity and rest breaks. You have to balance your activity with the rest. So just because you've got new lungs, and yeah, it's easier to breathe, and every time you move your oxygen doesn't drop, doesn't mean you can go run through and clean the whole house in one swell sweep and say, oh, okay, that's good. That was my exercise for the day. You've got to take the break still. Because if you push yourself too hard to where that later that day, the next night, you are just so worn out that you can't do anything, you've actually set yourself back. Because our goal is to be able to do something 4 or 5 days a week, right? Some sort of exercise every day of your life after transplant is ideal. So never wear yourself out to the point where you can't function the next day, you can't do anything the next day. All right, that's going backwards. You don't want to do that. You definitely want to move more than you sit. On the flip side, you don't want to sit all day ever. Sitting, you don't breathe as deep. You're not going to inflate your lungs very well, and that deconditioning sets in. It only takes days. It takes days. You can exercise for weeks to gain endurance and stamina that you can literally lose in days. So aerobic exercises are considered walking, cycling, stationary cycling. Don't get on a bicycle without your physician approving you to do that. Again, we don't want falls. Marching in place. People stand and march in place at their kitchen counter. It's still, you do it enough. If you're getting your heart rate up, it's considered aerobic. I do it in our gym. If they can't seem to do anything else, we march in place and we do sit to stands. Dancing, if you like to dance, put some music on. Dance to some music, just no super fancy moves. And then, of course, the treadmill. Strength and resistance exercises, armbands, hand weights, those type of things for the upper body. Now, that being said, post-transplant, you're not doing any stretching of the arms with the armbands post-transplant while you're in that precaution those first 3 months. The only thing we do with our post-transplant patients in precautions is bicep curls, or with the bands, we might do some triceps, but I don't even go there because too many people, if the form isn't perfect, you can still pull on the chest. But bicep curls is about all we do, okay? But that at least keeps your arm strength up. As far as the lower body, any of the leg exercises that you can do, if you've got ankle weights, if the leg exercises are too easy for you, you can add some weights, 1 pound. Be amazed how much a 1 pound weight on your ankle can amp up a leg exercise. We do things with people like leg lifts while they're sitting in the chair, what we call the extensions, just lifting that leg out. Hold your leg up and spell out the alphabet using just your foot. It's amazing how sore and how heavy that leg will begin to feel by the time you get halfway through that alphabet. So they seem like pretty meaningless exercises, but they can really build up some strength because all the while you're also managing that breathing, okay? The flexibility helps with your muscles. It decreases chances of injury. The flexibility exercises are much like warm-ups and cool-downs, things like your head tilts, okay, your shoulder shrugs, your shoulder rolls, calf stretches, hamstring stretches, things like that. You want to do those pre and post exercise anyway, just to you want to warm the muscles up, and then you want to cool them down when you're done exercising. Your breathing, probably the absolute, I don't know, respiratory therapist, maybe I'm biased, but to me, this is the most important thing. Those respiratory muscles, you had such a hard time breathing pre-transplant, and if nobody started you on any kind of respiratory muscle strengthening, post-transplant, they're probably pretty weak. We use a respiratory muscle trainer called the Breather at our center. And it's both an inspiratory and expiratory. So it's exercising all of your breathing muscles, both blowing in and out, as well as everything up in here. Speech uses it for people with swallow dysfunction. They're using it in our hospital for swallow dysfunction. So it's a great device. That's what we use. We also use an acapella, which a lot of lung patients know it as the pickle, the flutter valve. The flutter valve is way underrated. It has some resistance you can dial up on it. So that means when you blow into that thing, not only is it going to help you with mucus clearance, which, again, post-transplant, a lot of times people are getting bronchs because they've got mucus plugs going on in there because they don't have the strength, or the pain hits them. They're not coughing hard enough. That mucus sits down in there. So that flutter valve helps move that stuff around so you can get it out. But when we dial up that resistance, it's also working those muscles a little bit. So it's way underutilized, I think, but it's a great device. If you don't have one, ask at your pulmonary rehab center or your next doctor visit how you can get one. And then the incentive spirometer, if you've been admitted to the hospital, we all know what an incentive spirometer is. The device they give you, they come in all shapes and forms, but basically you're sucking in to see how high you can get, either a ball or a flap of some sort. That's another thing that is, people don't understand the importance of it. That's lung inflation. When you have a new set of lungs, you need to be started on that. I mean, we extubate you. We take the tube out after a lung transplant. We take the tube out and we hand you one of these things and say, okay, let's see how much air you can get in your lungs. Like right away, we have you on that. We want to get those lungs inflated. It takes a little time, and that's going to help a lot if you do that. We say do it 10 times every hour while you're awake. Split it up over the hour. You want to get those lungs inflated. Talk to you.
Can I ask on your exertion scale, would that be right around for blood ox, around 88 when it gets out of the green zone?
Everybody's different.
Okay.
Everybody's different, yeah. On sit-to-stands, if you haven't been asked to do them, I know some centers, they will do it as part of a frailty score. You're basically going to scoot towards the edge of a chair, and you are going to basically bend forward, nose over toes. You hear PT and OT say this all the time, nose over toes, and you are going to push yourself up with your legs to a full standing position, not using your arms. And then you're going to reverse it to sit all the way back down. I have patients, we start out only 3 to 5 at a time, because by the time you get to those last couple, they're starting to hit you. If you start, anybody in here who is looking at transplant in their future, start these tonight. Every single transplant patient that has come through our program since I took it over and has been transplanted, if I'm in the hospital and they got transplanted, I go see them. And every one of them have said, I'm so glad you made me do those stupid sit-to-stands. Okay, nobody likes them. It's the worst exercise. But it comes in handy that first time you got to get out of bed, because nobody can pull you up by your arms or anything. So, signs of overexertion. If you're having pain, tightness, I think it's not working, the timer, so I don't know where I'm at. If you're having okay. All right, I'm going to run through this real quick. So pain, discomfort, burning, tightness, anything in the chest that doesn't feel normal, stop. Post-lung transplant, you don't want any of those feelings in the chest. You don't want severe shortness of breath, meaning you cannot carry on a conversation. Okay, lightheaded, dizziness, headache, any of these things is overexerting yourself and you need to stop. Oh, this is my last slide. So all you got to do is remember to stop exercise if you have any of those overexertion signs. Don't exercise outside in extreme weather. Find some place that has a controlled temperature you can do it in. Balance your rest and activity. And if anything post-transplant is different, when you get released from that hospital and you get home, 3 days later you wake up and you feel a little congested, call your team, call your transplant team. You got a slightly elevated fever, call your transplant team. Your oxygen all of a sudden is a few points lower than what it has been since you got out, call your transplant team. Can't stress that enough. I have had to make that call for a couple patients, and I will tell you, one patient who didn't want to bother their team ended up admitted for bilateral pulmonary embolisms. I saved a life making that call for them that day. So when something isn't normal for you post-transplant since you were discharged, call your team. They want you to. You are not bothering them. Okay, it could be the difference between something landing you in the hospital or them calling in a script. Okay? Thank you very much.
Today, I'm going to talk about some of the long-term complications of lung transplant, including skin cancer and a few others. I have no disclosures. Sorry, I'm having trouble seeing my slides. I'm going to come over here. Okay, too short. So while I would love to spend my time up here telling you about the wonderful things about lung transplant, which I'm sure some of you have already heard, my assignment today is to really go over some of the longer-term sequelae of what can happen after a lung transplant. A lot of the education that you all hear about when you hear about lung transplant talks about the operation and a lot of the short-term things that can happen within the first year, because that's really where a lot of the complications arise. But we're hopeful that all of you would live, longer lives with your lungs, past 3 years, past 5 years. And when that occurs, there's some other complications that come up that you maybe don't hear about as openly in the lung transplant education you get prior to transplant. So we're going to spend that time talking about those things today. I'll start off giving a brief evolution of where transplant is, talk about some complications, and we're going to focus on cancer, chronic kidney disease, and then chronic lung allograft rejection. So you've probably seen a few similar slides like this through the summit, and you have to be a little careful when looking at graft survival, because depending on if you're looking at all comers, you're separating it out by age, separating it out by diagnosis, looking at all patients versus patients that survive past the first year, the graph can look a little different. And you also have to be aware that the graphs and these large registries that we have through the International Society of Heart and Lung Transplant, they lag behind. So our most up-to-date graph is actually from 2019. So when you think, we don't really have the numbers for 2023. But the big important thing to know from this graph is the white line, which is very hard to see, but the circle is around it, and the yellow line are looking at diagnoses of interstitial lung disease. So these lines are broken up by diagnoses, and the white line is IPF, and the yellow line is other interstitial lung diseases that are not IPF, so autoimmune, hypersensitivity, things like that. And this is basically looking at average survival. And as you can see, about 50% of patients live about 5.5 to 6.5 years after their lung transplant. While that number is not robust, if you do conditional survival based on who survives 1 year, which is about a 90% 1-year survival, that number can stretch a little bit. And like I said, there's lots of other factors that go into this. So you have to be a little careful of how you look at this data. Also, you have to remember that this number's actually come a long way, surprisingly, even in the past 5 to 10 years from transplant. So we are making progress, although clearly we're not there yet when it comes to long-term survival after transplant. And despite our numbers actually looking better, the modern era of transplant in the past 5 years has actually gone from a pretty conservative approach to taking on patients that are older, frailer, and sicker. So right now, the #1 indication for lung transplant across the world is interstitial lung disease. You can see from this graph here, that's the SRTR report, that the turquoise line is restriction. So all interstitial lung diseases fall into this category. And you can see that in the past 10 years, it's taken a major leap. And that's only to 2020. So with COVID, that's probably even higher now, is the #1 indication, with COPD being a close second. So it wouldn't surprise you, since most patients with interstitial lung disease lie in kind of the older age category when you look at transplant, that we're also transplanting older patients now. The brown line there is patients older than 65, and the turquoise line right above it is between 50 to 65 years old. And you can see that those lines really mimic the restrictive lung line right above it. So the average age of transplant right now is 57 years old, and 35% of patients are older than 65. That's pretty remarkable, considering that the guidelines 10 years ago said older than 65 was actually a contraindication to transplant. So we've come a long way. And along with that comes greater comorbidities. So we're taking on patients with more extensive coronary artery disease, with uncontrolled diabetes. Patients are more frail. And a lot of the scoring system has changed over the past 10 years for how we allocate lungs. And so maybe as a natural consequence of that, and as a consequence of taking on sicker patients, up to 21% of patients are in the hospital waiting for their lungs, and sometimes need to have life support devices such as ECMO, which is a device that basically serves to oxygenate your body outside of your body as a bridge to transplant. So as the field is advancing, getting more aggressive, taking on older patients, and with interstitial lung disease, the surgery itself can be a little bit more complicated because of the size of the chest and the scarring. It's really important that as a transplant community and physicians, we're focusing on these long-term consequences and complications that are going to come from this. When we look at complications over time, this is non-pulmonary and pulmonary, and a graph of time, you can see that the thickness of these bars are really big early on. So within the first few months of transplant is really where people have most of their complications, and that's really where a lot of the education gets focused on. The first 3 months after transplant is a full-time job. You're a full-time job being a patient. But as you can see at the 6-month mark, and then at my blue bars, which are the 1-year mark, those lines start to thin out a lot. And most patients have a good quality of life, they're functional, they're doing the things they want to do, and they're getting a lot out of their lungs. That being said, as the timeline goes on, there are some things that pop up after 3 years, after 5 years, that are, sequelae of getting new lungs and being on these medications. And we're going to focus our time today on those specifically. So we're going to start talking about cancer first. So obviously, malignancy is a higher likelihood if you've had any kind of solid organ transplant, not just lung. You're 2 times more likely to develop some kind of cancer if you've had a transplant of any kind. And while that sounds daunting, you have to remember that skin cancer makes up 40% of those cancers. So skin cancer is really the most common form of malignancy in all comers who get any kind of transplant. It's pretty high. You're 100-fold more likely to develop skin cancer if you've had a transplant. And other cancers can pop up too, and we'll talk a little bit about lymphoma, and then of course solid organ cancer like breast, lung, etc. Some of these are new malignancies, and some of these are cancer recurrences. So, of course, we transplant people that have potentially had a cancer prior to their transplant. We know that some cancers are going to recur, like bladder, potentially prostate. But we also know that those cancers don't progress very quickly, so maybe we take that risk on. While other cancers we know are really potentiated and get more aggressive with immunosuppression. And so we may have longer wait times prior to getting a transplant to let that cancer stay further away so that hopefully the recurrence risk will be less. Donor-derived cancer is very rare. So while we can't know everything about the donor when we accept the lungs, most donors have broad imaging, and any history of malignancy in a donor or any kind of suspicious nodule or mass anywhere in the body really would make us very hesitant to take donor lungs. So it's pretty rare. And then the major risk factor for malignancy in patients after transplant is actually your pre-transplant risk factors, just like anybody else. So age, gender, genetics, infection, all of those are going to play a role. But in the transplant community, you have the additive effect of some of these medications over time, which we'll talk a little bit more about. So let's focus on skin cancer. So not only is it the most common across all solid organ transplant patients, lung transplant patients specifically are at the highest risk. While we focus on it, not maybe right off the bat, you probably aren't going to hear your pulmonologist talking about skin cancer in the first 6 months because there's too many other things to talk about. But as you get to 3 years and certainly 5, skin cancer really can become an issue. Luckily, the most common types are the ones that are not as devastating to death, essentially, which is squamous cell and basal cell carcinoma. But melanoma, which can be very invasive and deadly, Merkel cell, and some of the other more rare skin cancers are still at a little bit higher likelihood than the average population. And not only are you more likely to get them, there is also risk of worse outcomes. So more recurrence, potentially distant metastases, and in severe cases, even death from skin cancer. There's an app called SunTrack for solid organ transplant patients, which you can put in your own personal your race, your age, if you've ever had skin cancer before, and what type of your gender, what type of transplant you've had, abdominal, thoracic, and you can get a little bit more of a specific gauge of what your skin cancer 5-year and 10-year risk are. When people think about skin cancer, I feel like a lot of times they think of this big, ugly, black, raised thing on their skin, but that's actually benign. When we think about skin cancer like squamous cell, which is the most common and can be the most invasive after transplant, they can be actually pretty subtle. And these are some pictures. So the big black thing is a seborrheic keratosis, which is actually a benign spot. And the 3 pictures in the middle are squamous cell carcinoma. So they can be a little scaly in nature and sometimes just look like dry skin. And a lot of times we find them in sun-exposed areas you can't see, like behind the ears, on the forehead, or back of the head, things like that. Basal cell is the other second most common, and it's the most common in the general population, but in solid organ transplant is second most common. Doesn't quite lead to as much detriment as squamous cell. And these are kind of pearly in nature. They're kind of raised, almost looks like a little pimple sometimes, but can also be quite subtle. Sometimes it can look like a little bruise, which is why it's really important for dermatology to be involved. This is just a chart kind of summarizing those, and as you can see, I don't know if I have, oh yeah. So the squamous and basal cell are the most common, and luckily don't really have as high as a mortality risk as these down here that have a really high mortality risk, but luckily are much more rare in the population. So why is there risk? So we've talked about older, male, fair skin. Those patients are at the highest risk, which is preset for us. But also, chronic sun exposure pre-transplant, having history of prior sunburns, really does increase your risk of skin cancer as well. And then the medications. So specifically, the immunosuppressants and the antifungal drugs, the azoles, have been shown to increase skin cancer in their cumulative effect over time. So some of that is related to the fact that certain medications are phototoxic, so they're absorbing the UV light in a much more intense way than you would if you weren't on the medication. But some of that is because the immunosuppression is knocking down your immune system, making you more prone to having certain viruses and certain damaged cells that then can promote further cancer. So how do we prevent this? Well, first and foremost, it's becoming much more known in the world of lung transplant and all transplant in the past 10 years. So everyone should have a dermatologist. PCP is not enough. Everybody needs a dermatologist after their transplant. You need to get minimal yearly skin checks. If we catch them early, it's pretty easy to treat. You freeze it off, you're done. You shave it off, clear margins, you're done. If it gets a little more invasive, a little deep, then sometimes we go to a Mohs, like a more deeper Mohs surgery. But if we catch them, then usually there's not a lot of sequelae. On the physician side, we're working to decrease immunosuppression, especially if you've had recurrent cancers, and if you're further out from transplant, that becomes easier to do. We try to get the antifungal drug off early, and there's a few other immunosuppressants that we can add that have a little bit of a protective effect, like the mTOR inhibitors. Sun protection is the most important, which we'll focus on here in a second. And then dermatologists may prescribe some treatments to help reduce sun damage if you have precancerous skin. None of these have been shown to be specific to post-transplant prevention. However, in the general population, they have, and they're pretty low risk and so worthwhile. The 5FU chemo peel, this is a lady who had it, her pre and post picture. And it's something that can really help with the pre-skin cancer, but it will make you look pretty rough for a week or two, so probably not the best thing to do like before the high school reunion or something like that. But maybe after, because you look really nice. And then the retinoid cream and the nicotinamide is a B3 vitamin that, again, there's no specific data that it truly helps prevent cancer in post-transplant patients, but over the general population, there's data, and it's pretty harmless. But sun protection is the most important. So data shows that if you wear daily sunscreen for 2 years after your transplant, it's going to lower your incidence of these common skin cancers, squamous and basal cell, and also prevent and lower your risk of getting a second skin cancer if you wear sunblock regularly. And then just practicing safe sun tips. So for example, between 10 a.m. and 2 p.m. is the highest UV light. And if you're near snow, sand, water, there's going to be reflection of those rays. It's even going to be a more dramatic absorption into the skin. So these are important times to seek shade. Sun protective clothing, which you can see here, this is extreme, but I wouldn't put it past people to wear this, and it could be actually appropriate. You want to look for the UPF label, which is a UV protection factor in clothing. And to me, the more you can cover up with clothing, the less sunscreen you have to put on, which is, I think, kind of nice. The big thing about sunscreen, everybody looks for the highest number of SPF, but actually that's not the most important thing. So the Dermatology Society guidelines, you need SPF greater than 30, but what you really need is water resistance, and you need to reapply. That's the most important piece. So make sure you're hitting all your sun-exposed areas, between your toes, behind your ears, and it has to be reapplied every 2 hours. Make sure if you're getting wet or you're running and you're sweating a lot, that you're reapplying even on a more careful basis. Don't forget lips. And then when you talk about sunscreen, you guys can look this up. There's the 1 ounce rule, where basically with a shot glass of sunscreen and using your short little fingertip here, you can look at this online. It'll show you how much sunscreen you're supposed to put at each place in your body for good protection. When we think about other solid organ, we think about lung. I'm going to just briefly mention lung cancer because that's the most common in lung transplant patients who are at higher risk. But a lot of that comes from your pre-transplant risk factors from smoking. So a lot of patients that get a lung transplant have had a smoking history, which is the #1 risk factor. if you get a single lung transplant, which a lot of older patients do, your old lung is at a much higher risk of getting cancer, and so usually doctors will screen for that by getting CAT scans yearly. Incidentally, we do find lung cancer 1 to 2% in the lungs that we take out, and that's because even though you're getting CAT scans frequently, with the amount of structural lung disease on your scan, sometimes there's little cancers that get missed, and so when the lungs come out and they're looked at under pathology, we sometimes do find a small cancer. And while that may not be anything important, we will always usually refer to oncology to ensure that we don't think there's any, microscopic circulation of cancer. And then, of course, the donor risk of tobacco exposure, which we try very hard to control for, and there's certain guidelines that we follow when we accept lung offers. We can't fully account for what that may be. But like I said, age, genetics, smoking, all these pre-transplant risk factors are really the most common risk factors for why people get solid organ cancer. And then immunosuppression can make this a little worse and speed up the aggressiveness of certain cancers. PTLD is a type of lymphoma which is basically an uncontrolled growth of lymphocytes that patients get specifically after transplant. And it's most likely related to a virus called Epstein-Barr virus, which almost everyone has been exposed to in life early on from saliva, and you wouldn't know it necessarily. So basically, when this virus gets into B cells, you really need your other lymphocytes there to attack infected cells and attack damaged cells so that they don't replicate. But because you're on immunosuppression to stop your lymphocytes from attacking foreign cells, unfortunately, they can't flag which one's infected, which one's foreign. And so basically, if EBV gets into your B cells, you don't have the immune cells that you need to stop it from growing and replicating rapidly. And so you can get what's called post-transplant lymphoma. Most of them are related to EBV. However, there can be other types as well. And it is the highest risk in the lung transplant population. There are certain risk factors, so being an EBV mismatch, which means we check this in your blood prior to transplant, and if you have never been exposed to EBV but your donor has, then you're more likely to get PTLD. If you're younger and if you have to get really intense levels of immunosuppression, you're going to be at higher risk. We see it occur at less than 1 year, and then a pause, and then what we call a bimodal distribution, meaning we can see it kind of raise up again at the 5-year mark. And usually we find it in the organ that's transplanted. So we see this in all solid organ, but in lung, we most commonly find it in the lung, lymph nodes, GI tract, and brain. Very vague symptoms, kind of like viral symptoms. And there's no real way to prevent, but we do monitor EBV viral loads in certain patients who are high risk. And if we see that pop up in the blood, that may prompt us to do further scanning. If people are having all these symptoms, we usually find some kind of mass in the scan, and then you would need a tissue biopsy to prove diagnosis. And the treatment is really to try to minimize the cancer, with any cancer really, by minimizing immunosuppression so that your body can fight the cancer or the virus that's going on, but also being careful to not cut your immunosuppression too low that your lungs start to reject. So it's a big balancing act. And the prognosis for PTLD it just varies so widely. You can see here 20 to 80%. So huge variability depending on where you find it, if it's in multiple sites, how far out you are from transplant, and if you have the ability to lower your immunosuppression. Chronic kidney disease is this vague thing that's really a diagnosis from the blood work and has different stages. And it's very ubiquitous if you live a long time with your lungs, up to 80% of patients. A lot of this comes from pre-risk factors, including smoking, which leads to hypertension and cardiovascular disease. A lot of patients have been on steroids pre-transplant for ILD or COPD, which leads to diabetes. Hypertension and diabetes are the two key things that lead to chronic kidney disease in the general population. But a lot of patients going into transplant have these. And then post-transplant, acute kidney injury is very common. Up to 50% of patients have a little bit of acute kidney injury at the time of their transplant, from low blood flow to the kidneys, from the surgery, things like that. And when these hits kind of start to accumulate, unfortunately the calcineurin inhibitors, which is the tacrolimus and cyclosporin, also over time cause renal damage. This is a picture in a microscope of an electron microscope of a rat's kidney tubule, or what we call glomerulus, which is a bunch of capillaries. And you can see here the AA is called the afferent arteriole, which is the blood supply to the kidney. And on that first picture, it's nice and plump and juicy. That's a very healthy glomerulus. You can see the one right next to it, which looks a little more frayed, narrowed, kind of falling apart. That is a glomerulus of a rat who's been on tacrolimus for years and years. So you can see here why that alone is not starting off in a great place. And so if you take a nephrotoxic medication or you get dehydrated and go into renal failure acutely, you're not necessarily going to have the recoverability that you would if your glomerulus looked like the other one. And that's basically just what this graph shows. So in the general population of group A, you may get some insult and you may get an acute kidney injury at some point in your life. But you can see by that pie graph that the majority of those people are going to go back to normal kidney function and be in that green group. Whereas if you've had a transplant of any kind, you have these pre-existing insults, you have the surgery, which usually leads to a little bit of insult, then you have these medications over time that when you get these acute kidney injuries, a lot of times you aren't going to have full resolution. And while you don't always feel symptoms of chronic kidney disease, and there's varying stages, we know that by having chronic kidney disease over time, there is worse survival and quality of life. However, we've come a long way in helping to prevent and minimize this. So we know that if you go into transplant with robust kidneys, you're going to live longer than if you go into transplant with non-robust kidneys. And so we're doing very close evaluation of renal function prior to transplant. After transplant, we're very standardized in following the kidney function closely. I mean, all of my patients, I'm like, drink more water, drink more water, drink more water, because you want that blood flow to be really robust going into that kidney. And then we're doing a really good job in medicine in general at new drugs and new techniques coming out to help with diabetes and hypertension, which are two things that you're going to continue to have in your life. And those are the two most common causes of CKD. So there's a lot more medications now coming out to help treat those things. And there's also newer immunosuppression coming out. While tacrolimus is still the mainstay, we're trying to do a better job at lowering the dose of the tacrolimus and to the lowest possible to protect the kidneys, and then adding in other types of immunosuppression that we can spare kidney function over time. And that's really where the field of transplant's going. I'm out of time, but last two slides I want to talk briefly, which is a whole topic in itself, of chronic rejection. So chronic rejection, which we call CLAD, is much different than acute rejection. And it's the inevitable long-term sequelae. So 50% of patients at 5 years are going to have some degree of chronic rejection. You may not feel it. It may be very slow moving, but it may be there. Kind of the same thing like chronic kidney disease. You may not know, and it may be subtle, but it's there. There's two types. So BOS, or bronchiolitis obliterans, is the most common one that we've heard, and that is the majority of patients, luckily, which kind of has more of a COPD type phenotype. It's slow moving. Patients kind of have this gradual decline, whereas RAS, which affects a smaller percentage of patients, has a more restrictive type phenotype, more like an interstitial lung disease. And you can see this graph, basically what you need to know is the orange top line are patients that have the BOS type, and the purple line, which is a little steeper, are the patients that have the RAS type. And the patients that have the RAS type have a much shorter lifespan and don't live as long. But regardless of which type you have, it is the leading cause of death long-term in lung transplant patients. And the diagnosis is not biopsy like you would see with acute rejection. We don't bronch for this necessarily, but it's based on your breathing test or your PFTs. So we look at your pulmonary function test, your best after transplant, and we watch, and as it falls, the most important thing your pulmonologist is going to do is make sure we can't find anything else. So anything else in this turquoise ball that could be affecting the lungs, but also the heart, also the vasculature, your GI tract, that could potentially be lowering your lung function. And if we can't find anything else, then we call it CLAD. And CLAD is a diagnosis of exclusion. So we want to make sure that we can't find anything else that's reversible. And even though we don't have treatment options right now that are truly effective, we know that a lot of different things that can happen early on, especially in the first year after transplant, can predispose you to having accelerated chronic rejection. And so we really have a more preventative approach to prevent reflux, to prevent acute rejection, to prevent infections and viruses that may come along that may lead you to getting CLAD earlier than we would want. Okay, sorry. Talking a lot and a lot of big topics, and maybe you feel a little heavy-hearted that, wow, like, okay, my lungs work, but now all of this. But I want to reassure you that a lot of these long-term complications really don't have and don't have to have a huge sequelae to your quality of life and even to your lifespan. If we're keeping on top of it, we're catching it early, they can be pretty easily managed over the long term. And these are some pictures that I have permission to share from my patients of what life can look like after transplant. And so even though we know that you're getting a transplant because obviously your life expectancy is short, and we know that the life expectancy after transplant is not yet where we want it, and there's going to be trade-offs. You can breathe well, but these are some of the trade-offs that are going to happen. At the same time, majority of patients I talk to, high majority, would tell you that it's still worth it and you can still have wonderful memories and create new joys in your life that you wouldn't have otherwise. And I just want to say the caveat, if you're not a transplant candidate or you think that lung transplant is not for you, because it's a really personal decision, that you can still find joys and quality of life in what you have. You just kind of have to redirect the lens a little bit. And I'll leave it there. Thanks.
So I am a double lung transplant. I had my transplant at the University of Virginia, March 19, 2017. So 6 years and 8 months. And I was double listed, so I could have either gone to downtown Baltimore or Charlottesville. I ended up in Charlottesville, which is actually my hometown. And it was the first time I'd been in a university hospital since I was a candy striper when I was 15 years old. So I just felt like it was meant to be somehow. I have no disclosures. I only have 20 minutes, and I have had a history of disease, lung transplant, and post-lung transplant for 15 years now. So I'm going to focus on thriving and how my life has been amazing since transplant. But just to give you my baseline, diagnosed in 2008, I spent 9 years on immunosuppressants before having a transplant. I actually was pretty stable during that time on a combination of medications. Then ended up getting more short of breath, went to pulmonary rehab, and went on from there. Someone mentioned 3 dry runs in the last session that we were in. I actually had 3 dry runs. The first one was sort of heartbreaking. The second one, I got all the way to the OR, but they were ex vivo lungs, and so they deteriorated over time. And by the time the third call came, we were like, should we really get out of bed? But on the fourth call, I got lungs. It was an easy decision for me to have a transplant. At the time, I was 60. I was working full-time as an NP. I had 2 sons. I have a great husband, and I had a 2-year-old granddaughter, and I just didn't want to leave any of those things. So, but it's not an easy decision for most people, and I appreciate that, and just, I think you need to look at your own situation and look at what it's going to require of you and what it's going to require of your family to make the right decision for you. So early on, after my transplant, I ran across a quote that was, I think it was the Pulmonary Performance Institute, and it said, "You don't want to look back and know that you could have done better." And I really took that to heart, and that became my mantra for my life post-transplant. So I used, these are what I call my 5 pillars, but I used a lot more things than that. Early on, I made really good use of denial so that I could continue to work with the diagnosis, and that, people talk about denial being a bad thing, but it was good for me at the time. I've also, I use gratefulness and mindful meditation every day, a dash of stoicism, sometimes the 20-minute cry, and then you feel better. And anything about resilience I'm sort of drawn to, whether it's a quote, an affirmation, a book, a movie, and those kind of things help me. So my main pillars, though, goal setting, which I've always been pretty good at, exercise, a positive mental attitude, support from others, and giving back. And you've heard this from almost every post-transplant person. I heard it twice in the last meeting. I have sort of divided my goals into personal and also exercise. So my personal goals. After transplant, I really wanted to give back in some way, and I'll talk about that later. And then my other big goal was just to spend as much time as I could with my family. Exercise, I am a huge exerciser, I always have been. And so I've tried to set goals for myself in 3 categories. One is just sort of a fun category, and those things are pretty fun. Attainable, and then also just a category slightly beyond attainable, just to push myself. Jamie was talking about pulmonary rehab. I was the patient who was like, why is pulmonary rehab only an hour? Like, I thought it should last all morning. I loved pulmonary rehab. But that can't be everything. You really have to be very active as you can post-transplant, at least 6 days a week, in my opinion. For me, it helps to vary my activity. I really try and push myself. And also steps. Steps are important, and I know they always talk about get a 1-level house and that kind of thing after transplant. We bought a 3-level house, which a lot of people thought was pretty stupid. But actually, it's been really great for my lungs. And so I would encourage more steps. You know, they say, how do you get better at steps? You do more steps. I also use sort of, I call it a positive mental attitude, but if you look at that slide, that's sort of more a tough love kind of attitude. I have a brother who's an Army Ranger, or was an Army Ranger, and so he sort of tells me that things like stop whining, you know, work harder, get up, just keep getting up, and I'll use that along with more positive means of self-talk, like reminding yourself of your strengths, reminding yourself of your past successes when you're feeling low, hanging around with people who lift you up, and I'll also use altruism, which is a wonderful thing to do when you feel bad about yourself, is to do something for someone else. I have had some complications, but the majority of those were in the first year, so I sort of don't count those. I do have a narrowed bronchus, which I know that Sam spoke about his narrowed bronchus earlier, and don't worry, that typically is like less than 10% of lung transplants. We just both happen to have that happen. So my bronchus is a little bit narrower. It's like a 3 millimeter typically, and it makes it harder to get mucus out. But I have employed I have all kinds of things that I use in my repertoire, including, as a last resort, having my husband beat on my back. That is a chest vest, which also helps. I didn't have that before transplant, but I do need that now. I've had some funguses. I have had some skin cancers, but I haven't gotten COVID yet, so that's a good thing. I didn't put delirium on that slide, which I don't know why I didn't. I tried to block it out maybe, but that was probably the worst of my complications. This is a very partial list of some of the things that I've been able to experience since transplant. It's too overwhelming to even think about all the miracles that I've had since transplant, but I'll start with the fact that I've had a grandson be born since transplant. He's now 4, and I just would have been a lady in a picture to him had I not had that. My granddaughter was 2, and now she's 8, and we like to do cool things together, like we've been parasailing together, boogie boarding. and scootering. Some people, you can see my list there. Some people buy shoes. I tend to buy exercise equipment. I could open a gym, but I couldn't let anybody in because of COVID. My husband and I celebrated our 40th wedding anniversary. I've gotten to spend huge chunks of time with my sons and their wives. My husband, in his caregiving talk yesterday, mentioned the 4-miler at UVA that I did. That was actually 4 months after being in the hospital for a month. I was really weak when I left the hospital, and I saw that 4-miler in some publication, and so that was a time when I said, okay, I'm going to set this as my goal. And I did make it, and I did 20-minute miles, and then I found out 3 days later I was in rejection, so that's pretty good. I also was able to move back to my hometown. That wasn't something that we had anticipated doing. You know, we had a life in Maryland, which is where we lived, but we ended up, my husband fell in love with Charlottesville and the time it took me to recover, and we just went back to Maryland. We did the thing that they tell you never to do when you're in a trauma situation. We made all the big decisions. We put our house we went back to Maryland, put our house on the market. My husband retired from a federal job, and it was the best decision ever. These are just some of my support people. There's some of my team members there, my brother, my grandchildren, my friends, and my family. So many people surround you when you're recovering from a lungs transplant, and it's just been wonderful and life-affirming. The way that I've given back is in part of being a PFF ambassador, the class of 2018 to 2022. As soon as I saw that they had PFF ambassadors, I wanted to be one. And that has been a great experience. The PFF walks were really fun. They allow you to sort of do whatever you want with the walks. So one year I sang Motown songs for money. I delivered homemade shortbread to people for donations. Another year I sort of got tired of asking the same 100 people for money. And so my dog and I just pledged per mile. But they give you the freedom to do that, and I really enjoyed that. The most important, and I'm a Donate Life ambassador as well, but the most important thing I've done and continue to do, I'm a lung transplant mentor. That's a program I haven't heard of at any other institution, so I think we may be unique in that. But our social workers set up this program quite a while back, and as patients are being worked up for transplant, or maybe even already in the hospital after a transplant, they're asked if they want a mentor. We're able to come in, visit them in the hospital, get them whatever they need, bring them anything that you think will engender a little more hope that you can have in an ICU. You become their mentor for life. So I have currently, I think the other day I counted up, I think I've mentored about 30 people. And not all of them need you after the first couple of months, or some people don't really need you very long at all. But a lot of those people I think I'll be keeping in touch with for life. This is just a thank you. My husband's been there. He didn't marry me to be a caregiver for 15 years, but that's what happened. And we've tried to make the most of it. I think it's brought us actually closer. There's different phases of that whole caregiving patient process. So in the beginning, he wasn't very involved. Then around transplant, you become dependent on that person, and he was doing everything for me. And now he's backed off a little bit. In fact, sometimes I have to tell him to back off a little bit because I can do it. But we're working as a team now, and we're looking at life forward and together. And I think that's it.